Dr. Audrey, who's the keynote speaker today, who will be talking about the use of YAG laser for treatment of epithelial ingrowth or implantation in post-laser vision correction.
Thank you so much. Thank you so much for the invitation. It's just a cute cat, and I really like cats, and so that's the only significance there, none other. And my slides, let's see, are not advancing. There we go. No significant financial disclosures. When we discuss epithelial ingrowth or implantation, when we're talking about a LALEX or a SMILE excuse me, procedure, we're really discussing epi-implantation, because these we see within days or weeks of the procedure generally, and basically it means that maybe the eye was a little bit dry, the epithelium a little bit loose, and inadvertently you deposited some epithelial cells in there. This is different from true epithelial ingrowth. If it's a small area or central, as we see here in this photo, or within a few months of the procedure, then I recommend surgical removal rather than YAG removal. With LASIK, we're usually talking about true epi-ingrowth. This means that there's a channel that has been created where the epithelium actually grows in. This can be secondary to trauma. We've all seen those late flap dislocations. Also eye rubbing. I always ask about eye rubbing because sometimes it's very curious. You'll have a patient and they did well and you see them for some reason. There's maybe a little change in vision. It's even years later, and they'll have epithelial ingrowth, and you know from your chart notes that they did not have epithelial ingrowth up to this point. And so always ask about eye rubbing. If it's recurrent epithelial ingrowth after an initial surgical removal, then I also consider recommending the YAG laser. So when do we remove epi-ingrowth or epi-implantation? Obviously, decreased vision involving the visual axis, irregular astigmatism, so you really want to pay close attention to your tomography and topography, and of course if you're concerned about a flat melt. I'm going to describe my procedure first and then show you a video with the description as well, and I think that this really helps to cement that procedure. Place your topical anesthetic of choice. You can use a lens or not use a lens. It's entirely up to you. I set my YAG at 1 millijoule, and you can go up or down from there. I place a few spots, and what you'll start to notice are these bubbles that occur in the white area. And you just keep hitting until you have lots and lots of bubbles, and again, you'll see this next on the video. You can adjust your power a little bit up, a little bit down, but starting with a mild level there is good, and you continue with as many shots to the area until you'll see the bubbles. It's almost like playing a video game or something. You'll see all the bubbles dissipate the white epithelial cells, and it will take more than one treatment. So it's not a one and done situation. You want to counsel your patient. You're going to do one treatment, and then a couple weeks later you'll be seeing them back, but then a couple weeks later, usually a second. I found that it takes an average of about 3 treatments, and this is for significant epi-ingrowth. So here we have a video. This is my friend Dr. Dagny Zhu, and you can see here we'll start, okay, and see there's the bubbles right there, and so the bubbles are starting, and looks like that power is great, and you just continue in that whole area, and you'll see these clear zones and these bubbles forming, and essentially once you have this appearance, okay, and the white area is dissipated, that's when you can stop. Again, if it's small and peripheral or not impacting vision, if you have ingrowth or smile or implantation, you can simply observe. You get that demarcation line that we all know and love when we see those, we're used to seeing it with LASIK patients, and you see that little demarcation line. If it's peripheral and I see a demarcation line, I'm really not very concerned about it, and you can just observe. And sometimes this will go away, and it can take really months or even years. If it's recent and really epithelial implantation after SMILE or LALEX, then I recommend going back into the incision and using, oh, that's lovely. It's very dramatic. And I like dramatic talks. Feel like I should break into a dance movement or something. Anyway, you can go back into the incision, into the smile pocket, get it with a Sinski is what I like to use, and you'll see it just come right out. You then check with the slit beam under high power. Be sure that epithelium is removed. Really important. And if it is late epi ingrowth with smile, then I consider YAG laser removal. This was a case, very small area of implantation after smile, and this was noted really within a few days. You're going, is that, some ingrowth there? Is that an implantation? And you have that denial. Denial is a very popular force that we all have as surgeons. You say, oh no, it really does exist. Okay, that's fine. I should go back and remove it. And this is the tomography looking before and after, and you can see there's definitely a change, and this was really right after. This was a case of true epithelial ingrowth. Looks like ingrowth after LASIK. And this was a woman, she was an optometrist, a referring optometrist to my practice. I did her smile, she's doing great, and then she came back and she had what's really ingrowth. She did not want to have it removed because it turns out that she was newly pregnant and she wanted to try and avoid any procedures that she could. And so we opted for YAG treatment. And you could see the before and after one YAG laser treatment, a lot of that has dissipated. It did take about 3 treatments for that to resolve. And for these peripheral epi ingrowth cases, I find it's really, really helpful. Here's a case of LASIK. Essentially, again, if it's peripheral, stable, there's a demarcation line you can simply observe. But if it's peripheral or extensive or causing irregular astigmatism that you can certainly see on your tomography, topography, then you want to consider a YAG treatment. Noting the blue arrow, you can see that whitish area there, and that's a significant area of epi ingrowth. It's white, it looks active, I don't see a demarcation line. And again, you can see the treated area. We've all seen these late traumatic flap dislocations after LASIK. Obviously, we need to reposition the flap. That's first and foremost. You can remove any epithelium that's underneath. And here I reserve the YAG for residual epi ingrowth, which there usually is, or recurrent. Here again, we see this was the flap reposition and using the YAG laser here for the residual epi ingrowth. Postoperatively, I use a steroid TID for a week. I follow up in 1 to 3 weeks, and then again, you need to repeat the treatment. So you want to make sure to counsel your patient. It's not a one and done situation. They will probably need several treatments. You want to look for the regressed area of cells. Remember, when you're doing this, when you're doing the YAG, just go ahead and blast away until you see all of those bubbles and that white area dissipates, and it'll kind of move around a little bit. Not to worry about it, it's fine. I do recommend, even if you're not using a lens, still use some topical anesthetic because it does have some discomfort. And then obviously, postoperatively, look for that demarcation line. Thank you so much.
Thank you, Dr. Audrey, for that wonderful talk. Is there any kind of thickness of the epithelial ingrowth or density that you would say the YAG would not work for, or that is immaterial, the depth of the epithelial ingrowth?
Yeah, I found, as you could see with that case that I showed of the optometrist, it really was pretty thick. It was a confluent white kind of milky appearance. And if you use the laser and you'll see all those bubbles will definitely dissipate that area. So especially for these peripheral cases, I think that it really works quite well. Or in cases of, it's their second or third recurrence, those cases that are referred to us where the primary LASIK surgeon already removed it perhaps, or even you've removed it and it comes back, it's recurrent. We all know that with more flap lifts, it's just going to keep coming back. And that's where I think that the YAG laser treatment really shines.
Amazing presentation, Dr. Audrey. So, will this be your first line of treatment if you find these epithelial cells, or you would also try to wash them or use medication and then keep this as the last line?
I think it The answer is it depends. If it's a case of like a smile, usually that's epi-implantation. I'm going to go in, I'm going to remove it because it's usually within, days to weeks out, right? It's very early. If it's LASIK and it's early, it just depends on where it is. If it's more central, I'm going to surgically remove it. But otherwise, in the periphery, if not causing any vision changes, I'm going to observe it, get the demarcation line, or not. I really like using the laser at that point.
I think we had a question from the audience as well.
Yes. So the question is, do I do a lens when I'm doing this? I personally don't. I've used a lens. I've not used a lens. I really don't think it makes a difference. I think it depends on the patient. If you have one of those patients, like, who's going like that, you might want to use a lens. But otherwise, just the topical proparacaine, I think it's just fine. So whatever your comfort level is, I don't think that you absolutely need to or don't need to use a lens.
Also endpoint, like you decide that it's enough and I don't want to do any more. I mean, how do you decide that?
As I was explaining, it was asking the question here of what is the endpoint. And basically, you just see that those cells have dissipated. It's that white area. You'll see lots and lots of bubbles. And when you think, okay, I've done enough, I have enough bubbles here, a lot of the white has dissipated, stop. You're going to be seeing the patient back. And you know that, yes, you're probably going to be having to do another 1 to 2 treatments.
And one last thing, when you said that you re-enter the interface in a post-lenticular surgery, how many days you think you can re-enter and find the right plane?
So the question is, how many days can you enter and find the right plane? I'd say up to several months. So up to about 3 months, I think it's not really a problem. Beyond that, I think it's more significant. So I guess the thing is to make sure the patients are coming for their post-ops, especially early on, because again, if it's really, if it's a smile or lenticle procedure, and it's usually epi-implantation, you're going to see that early on. If it's peripheral, it's more likely to be epi-ingrowth, and then a YAG can work. Great, thank
So
you.
for post-smile, how do you go about manual removal? If you have a central island in the visual axis, what is your approach?
What is my approach for that? I go in with a little Sinskey hook.
Okay.
Okay, and so I just basically go in, and then you'll see, you'll be able to kind of hook those cells and just simply drag it out. You can also use your lenticle forceps. That's another method too, or that spoon dissector. But I find I just go in with a little Sinskey very, very gently, right? Because we don't want to be disrupting those cells there. Well, the good cells, right? We want to get the epithelial cells out. But I just go in, and you can see, and you'll just catch it, and then you can either just drag it out with a Sinskey, or you can go in with your lenticle forceps and simply take that out. But then you want to really make sure afterwards that all of the cells have gone, that you can see, and also make sure that that the cornea is hydrated, because probably what happened is you had loose epithelium, you dragged it in the first place, and so you want to make sure that you're not going to be dragging more in and then chasing your tail.
Thank you so much.
Since you do lenticle surgery, I want to know that in a decentered lenticle, have you ever had any experience of doing a trans-PRK to treat the aberrations and centering the treatment post lenticle surgery?
I actually,
because I have one or two cases of a superior decentration and contemplating how to treat them.
there you can consider, that's where you could consider the topo-guided treatment. Yeah. It just depends, but yes, definitely topo-guided.
I would still look at the epithelial map if you
Yeah.
could, because yeah, it can be done. Transepithelial can be done, but like I said, it depends. If there is hypertrophic area of epithelium, then that may interfere a little bit. So that is something that we need to look at. Yes.
When you are manually removing those ingrowths, are you using mitomycin C
Mitomycin C for?
on the bed for some time?
Surgical removal of
In the
ingrowth.
surgical removal.
No.
So any role of mitomycin C to prevent recurrence again?
No, I don't really think, mitomycin C can prevent haze, right? It can prevent subepithelial haze, but not indicated for epithelial ingrowth.
Okay, thank you.
I don't use alcohol either, no. Usually just a normal Sinskey can do it, or those lenticle extraction forceps are really helpful too.
And you
Yes,
said
one.
the energy is 1 millijoule. How do we know sometimes while hitting that we might need to increase the power or decrease?
Because you won't see bubbles.
So that means you
Yeah.
increase. And when do you know that the power is too high?
You'll see it'll be like a blast. It'll just look
Okay.
like, you know, fireworks, sparks are flying. That's a little dramatic. It's not
Yeah.
really like that, but it's a little bit more dramatic, and I don't really like too much drama. Okay, I'm kind of drama-free. Drama-free zone.
Yes.
That's that white line that you'll see outside of the area of epithelial ingrowth. You'll see it, there'll be epithelial ingrowth, and then there's this white demarcation line. If you look carefully, you'll see it.
What would be the setting on the YAG? Will it be anterior, 0 or posterior?
I do anterior.
Anterior. Thank you.